Hello, everyone. Thank you for joining the 11th edition of the International Workshop on HIV and Aging. I know we're spread across several different time zones, so I was going to say good morning from where I am on the West Coast, but I know it's mid-afternoon and evening in other places. So wherever you are, welcome. And that welcome is on behalf of my fellow co-chairs, the organizing committee, the scientific committee, and I wanted to extend my warmest welcome to you. So next slide, please. So I wanted to make note of the fact that we have 166 registrants to this workshop, representing 19 countries around the world. I think that's quite tremendous and should provide us with a nice, lively discussion and help us obtain our objectives. Before we get started with the formal program, I do want to share some unfortunate news. Many of you may know already the sad news of Timothy Brown's passing due to leukemia. Likely many of you also know that Timothy was the first person to be cured of HIV. Mark King has a nice blog, and if you can't find it, please let us know, celebrating the life of Timothy and appropriately identifying him as a real hero. So it's with condolences that I share that news, but I wanted to make sure that everyone was aware, and our heartfelt thoughts go out to Tim, his partner, as well as those who knew and loved Timothy. With that, I'm going to go into our program objectives. So what we have here, we're really looking even more broadly, before I go into the points here, is to really improve and inform the lives of older persons with HIV through research, education, engagement, and discussion. So we want to identify age-related complications in older individuals with HIV. We want to identify those latest scientific findings and see how we can adjust and move forward with trying to improve the lives of those individuals. And really, I hope that we can lay out a roadmap in our discussions for what we can do in the future. And next slide, please. There is CME accreditation for this, and individuals will get 6 European credits, and GOTA and Victoria will have all the information on how to do that. And it's 1-to-1 equivalent, I believe, for this, and GOTA and Victoria can help me with that. Next slide. So we have several groups supporting us, NTAP and Jules Levin, CFAR, as well as GMHC, which are all supporting and endorsing this program. So we thank those groups and appreciate their input as well as participation. Next slide. And we have our corporate sponsors as well. The platinum level is ViiV, as well as the gold level MSD. So again, those sponsors really help us run a very organized, as well as provide certain benefits to us in this conference. So thank you to those sponsors, greatly appreciated. And next slide. Okay, Jules is going to give us a introduction and on behalf of the community. So I'm going to throw it to Jules to give us a warm welcome on the community's behalf. So Jules.
Hello, everybody. This is Jules Levin. I want to open my brief comments and for the opening of the Aging Workshop to bring your attention to this table from the CDC, which of note is from 2015. And focus on the red bars on the right, and you'll see that 450,000 people are over 55 right now in the United States. Of note, 70,000 people are now over 70, and 150,000 people over 65. What this shows is really the aging elderly population in the United States. And as time marches on, these numbers will increase, the percentages will increase, and people who are becoming elderly with HIV, this is our first generation of elderly people aging with HIV, and we're facing a very serious problem. I call this an explosive problem because it's not getting the attention it needs, and I would essentially say that it's not getting any attention. I've been talking for the past several years with local, state, and federal officials, and I find them unresponsive to the problem. The problem, as I see it, is that we need an HIV care infrastructure that needs to be overhauled, that meets the needs for the care and services for the increasingly aging population, which it's not 50%. The general discussion is, oh, well, 50% of people with HIV are over 50. As you can see, when you look at it in more detail, a high percentage of people, 30, 40, 50, 60%, are aging over 50, over 60, and over 70. And soon we're going to have many people over 65 suffering from the double hit of aging, the double hit of the effects of HIV and the normal immunosenescence that all aging people experience. So people with HIV are experiencing 2 to 5 numbers of comorbidities compared to similarly aged HIV negative people, including all the usual comorbidities that people with aging experience: cardiovascular disease, kidney disease, bone disease and fractures, and frailty, cognitive impairment, cancers, physical impairment. We need a care infrastructure that meets the needs of our growing elderly HIV population. And an important note was at CROI this year, a study from Kaiser finding a 9-year difference in reduced mortality for older people, for people living with HIV compared to HIV negative people. That's a 9-year mortality reduction for people living with HIV. Not to mention the quality of life for these elderly folks suffering from multiple comorbidities is horrible. I can tell you from personal experience here in New York, due to the evolving changes in insurance reimbursement and the restrictions in reimbursement to large and small hospital HIV clinics, these clinics are increasingly restricting time for medical visits to 15 to 20 minutes for people living with HIV and their doctors. It's impossible to provide the care and the services people living with HIV need in a 20-minute visit. Something has to change. And I see no movement from local, state, and federal officials on this issue. So for the first time, due to having a virtual meeting, so many community people are now tuning in and have registered to participate in the only aging workshop, our aging workshop. And I wanted to frame the discussion during this workshop for you folks to focus on this particular issue and to keep in mind as we go through the next day to 2 discussions during the aging workshop. We need a change in care and services. We also need better research that meets the needs of elderly people living with HIV. Research that finds real-world solutions for our health concerns and quality of life concerns. Thanks for tuning in.
Thank you, Jules, for your passionate advocacy. It's greatly appreciated and really helps us frame this meeting to be what it should be, which is focused on the community, for the community, to try and understand how we can best serve people who are aging with HIV. So thank you again for those words. I wanted to let people know about today's program in general. We have the first session, which talks about the major gaps in pharmacological and pharmacology of aging, and that will occur right after this intro. And then we have our abstract-driven presentations, and finally our lightning poster presentations to give better chance for us to see as many different posters and presentations as possible throughout this meeting. So that is the plan for today in terms of the program. Next slide, which is about how to ask questions. So you'll be able to see and click on the Q&A field to be able to type your questions. Importantly, chairs and session chairs are going to try their very best to moderate those questions such that if we get too many questions, we'll do our best to collapse questions into one broader question. Chairs are also asked to prioritize and try and ensure that community members have a chance to have their questions asked, as well as the big picture questions that we all want to think about. Importantly, for people who may be hesitant to ask a question, there is an anonymous box where you can click and post your question anonymously. So please make use of that if you would like to. So that's the questions. And next slide. And finally, in order to get your certificate of attendance, you do need to complete the survey, which will be given to you after each session. After the meeting is over, you will receive an extensive survey to let us know how the meeting went and what we could have improved upon and what went well. The certificate of attendance will be sent to you via email. Next slide, please. So here we are on session 1. What are the major gaps in pharmacology and aging? The chair is Charlie Flexner, and I'm going to hand it off to Charlie now.
Great. Thanks, David. Thanks so much. I'd like to thank all of you for being a part of this 2020 version of the International Workshop on HIV and Aging. We've been doing this now for more than a decade, and this, I think, will turn out to be one of our most memorable meetings, although it's not exactly the format I think any of us would have hoped for. But it's going to be a terrific. It's going to be a terrific group of sessions, and I really hope that you will participate in as much of the meeting as you are possibly able to, because we have a terrific lineup of speakers and abstracts. The first scientific session is entitled, "What are the major gaps in pharmacology and aging?" We will have 2 didactic presentations followed by a period for questions and answers and discussion. And we're scheduled for a 10-minute break at 3:05 before we go into the next session. And with that, I would like to introduce our first speaker, who is Andrew Clark from ViiV Healthcare. Andrew did his medical training in South Africa and has worked at ViiV for a number of years, where he is currently the program leader for HIV and Aging. And Andrew's talk today is entitled, "What are the major gaps in pharmacology and aging with HIV? A Pharma Perspective." Andrew, it's a thrill to have you with us, and we look forward to your talk.
I'm delighted to be able to share with you some of my perspectives on what I think are the major pharmacology gaps in aging with HIV. These are my disclosures. I'm an employee of ViiV Healthcare, and I own shares in GlaxoSmithKline. Like other chronic viral infections, HIV manipulates multiple key cellular processes to ensure its survival. And many of these are also coincidentally the same processes that determine aging. As an example, envelope has pleiotropic effects on many different types of cells, such as endothelial cells, epithelial cells, cytokine and chemokine regulation, and various intracellular signaling processes such as autophagy and various aspects of cell program death. So over time, these result in local and systemic pathology. And as you can see on the right-hand side, a whole list of multiple comorbidities that we typically see in the setting of older people living with HIV. Exactly how HIV manipulates this and how the age-related pathology fuel each other is clearly a very complex process, but it is evident in the spectrum of diseases that we see in managing older people living with HIV. This has particular relevance to the drug selection and drug discovery process, both in terms of novel targets, but also ensuring that drug development considers age-associated diseases in terms of organ function, drug interactions, and age-appropriate clinical endpoints. HIV is associated with this broad spectrum of cellular pathology. And over time, these multiple different cellular aberrations accumulate either local pathology or systemic pathology. And we see this accumulation of different comorbidities as listed in the middle. I think what's really particularly interesting is that many of these, of course, are also associated with aging. And what we're seeing in HIV, as evidence from multiple cohorts like Aging, HIV, Age HIV, and POPPY, is that these are clustered. And this invites speculation that potentially there are common pathogenic pathways and therefore maybe also common interventional opportunities, either specifically against HIV or against some of these age-related or HIV-associated comorbidities. So at the cellular level, HIV interacts with a host of proteins, and particularly the HIV envelope, TAT, and NEF, and several other proteins are implicated in this. These interactions are still being explored, but many of the cellular processes that HIV manipulates, as I mentioned already, are also some of the processes that are really important in determining age. And just as an example, you can see in the middle that just the interaction of CD4 or the chemokine co-receptors CCR5 or CX4 can result in intracellular signaling that determines multiple different cellular processes such as transcription, cell migration and adhesion, cellular survival even, and even programmed cell death. And on the right, you can see the striking difference between the stimulation of envelope, depending on whether it is a CCR5 tropic or CXCR4 tropic envelope. And you can see from this heat map that the intracellular activation of protein transcription is vastly different between these two, just highlighting once again the complexity of how HIV manipulates various cellular processes. So the industry response is manifold. First of all, and very obviously, our interest in the basic science for drug discovery and target selection, and exploiting the various molecular manipulations of HIV. This means that we are obviously really interested in a lot of these different pathways because they may offer us a variety of different targets, not potentially just for HIV, but also for other related diseases. Of course, our global network of clinical sites means that we have an extensive reach, and this reach should ensure that at least we are able to include the participation of a vast spectrum of different people living with HIV so that we can ensure that we have a good representation of different populations, including the elderly and pediatrics. But the inclusion of elderly is lacking for several reasons. One is because some of the sites that we typically engage in don't necessarily have this population, but also because people living with HIV as they age have often been exposed to several different regimens and therefore heavily treatment experienced, and they don't necessarily benefit from some of the newer, simpler regimens that are on offer today, such as the single tablet regimens, and also some of the newer strategies, such as the reduction from triple therapy to dual therapy. However, there are multiple novel mechanisms of action and even novel routes of administration which might well benefit this population. But we really have to consider their specific needs, such as the decline in organ function, different ways of metabolizing drug, and understanding and preparing for potential drug interactions and different toxicities in this age group. Cohorts and observational studies are incredibly important because they often address some of the shortcomings of the clinical development program, and we can specifically target populations like the elderly. And so there are several cohorts that we do support, such as Age HIV in the Netherlands and POPPY in the UK and several others around the world. But on their own, they are still somewhat lacking, and there is a renewed interest in the regulatory agencies to ensure that observational studies specifically address some of the shortcomings, and particularly around the aspect of aging. Implementation science is a fairly novel avenue for the pharmaceutical industry, but the utilization of the implementation science methodology ensures that we can revisit how the various clinical trials that we do address the access to care, the optimal healthcare, and implementation of an improved process so that the capabilities that we have should benefit this population. Educational programs, I think, are also somewhat lacking. We've obviously been doing these for many years, but I think given that we are now needing multiple other disciplines to assist with the care of people living with HIV as they develop all of these comorbidities, we really have to extend our reach in our educational efforts to all these other disciplines, such as oncologists and cardiologists, neurologists, endocrinologists, and geriatricians. And the community engagement is also clearly something that we have done for many years, and it is the community engagement that has ensured access to care across the globe in a way that is unique to HIV. But the insights that we can get from the community are still somewhat lacking. So there is a program that has been run now for several years called Ad Hoc, Aging with Dignity, Health, Optimism and Community. And this is an online program including over 1,000 people now over the age of 50 across multiple sites in the US, and exploring several aspects of their living with HIV. But not only are we able to gather the insights that are part of the program, but also now introducing interesting ways, including implementation science, to ensure that this has an impact on better care for this community. Clearly, our support for non-government organizations around the world is also important, but these continue to change. We often see, particularly under the circumstances of COVID-19, them being particularly challenged. So our continuous support of this group is really important, but also being able to identify new NGOs so that we can always ensure a very broad spectrum of support. And then finally, as an industry, we, I think, are in a unique position to be able to shape public health and policy. And it is really critical that we ensure that we address the multiple areas where either discriminatory laws or discriminatory policies inhibit access to care, because as an industry this has been quite obvious, particularly in areas, in countries where, for instance, stigma is sponsored by the state. This is just an example of a meta-analysis that we have recently conducted on all the dolutegravir studies at ViiV Healthcare, and this data will be presented in more detail at the HIV Glasgow meeting in a couple of weeks' time. But just over 1,000 participants in various phase 3 studies in treatment-naive patients, looking at the health outcomes for different age strata of less than 50, 50 to 65, and over 65, you can see, as you would expect, the increase in the numbers of prevalence of comorbidities in cardiac, gastrointestinal, metabolic, nutrition, nervous system, and psychiatric diseases, as you would expect, increasing with age in both the dolutegravir and the various controls, and the various comparators. So the regulatory approach to the elderly is a relatively recent. They're often described as a special population, but of course the elderly are the main consumers of medicines. So they're not really a special population in the same way that pediatric population is. The ICH works closely with the various major regulatory agencies as shown here. And the main intention of their approach is to ensure that the study populations that are studied in development of drugs includes the spectrum of people that are intended for the use of that, and where those diseases are more likely to occur in elderly, to ensure that those programs are enriched with older participants. This, of course, has always been a struggle, even in disease areas where age is much more associated with those diseases such as cancer. This has been, as I said, somewhat of a slow progress. So this started off with a guidance that was issued by the FDA in 1989 for the development of the use of drugs in the elderly. And this was followed a few years later by the ICH E7, which was guidance for the industry of special populations, including the elderly. And then over the next few years, the agencies continued to develop their strategies, and the EMA published their geriatric medicine strategy in 2011. And this was followed by a publication the following year in the New England Journal of Medicine of this strategy, but also their evaluation of how this strategy was being applied. Over the next few years, further guidances and draft guidances were issued. Most recently, the FDA issued a guidance on how post-marketing studies, for instance, could address some of the shortcomings of development programs where people are lacking, older people are lacking in the participation of those studies. And most recently, this year, the FDA issued draft guidance specifically focusing on enhanced inclusion of older people living with HIV in cancer studies. Of course, the intention of the regulatory agencies is to ensure that there are better information for both prescribers and consumers, and to ensure that there are age-appropriate inclusion of older people in studies where they're likely to be the recipients of those medicines. But this is a little different for HIV, where of course younger people are infected and then age with their infection, rather than being infected predominantly in an older population. And of course, finally, the enhanced need to reconsider some of the clinical endpoints that are much more age appropriate, such as frailty potentially, and this unique safety aspects that we are more concerned about in the geriatric population. These are some of the major areas where I feel we need to address to ensure that HIV does not hijack the process of aging for people living with HIV. HIV, as I mentioned earlier, manipulates multiple molecular pathways and cellular functions, and these often coincide with the aging-associated processes such as autophagy, and this profoundly impacts critical cellular regulation, cellular defense, stress response, and phenotype. This complexity provides some challenges, but I think it also provides several opportunities, and those opportunities, if addressed, may well benefit well beyond HIV. Persistent immune dysregulation and inflammation are hallmarks of HIV, both locally and systemically. But exactly how this intersects with age-associated inflammation and immune decline, I think also has implications for future care of people living with HIV. Minimizing inflammation seems attractive, but I also think we need a far better understanding of the drivers of inflammation, and how to restore an overall immune function despite aging. Senolytics and senostatics are very promising and are being explored to address several age-related diseases. But of course, one of the drivers for senescence is the prevention of cancer. So as we start thinking about the introduction of these into people potentially living with HIV, we need, I think, to address some of the safety concerns, and also whether in a setting where we already have enhanced possibilities for cancer, that we don't unleash this in this population. Women with HIV differ from men in several ways. First of all, they have enhanced CD8 activation, interferon gene expression, and more inclined to have multiple comorbidities. And that is aside from the obvious neuroendocrinological, neuropsychiatric, and musculoskeletal complications and manifestations of menopause. So while I think there are several gaps in our understanding of how HIV is driving this, I think there are also major gaps in how women are managed as they age with HIV. And perhaps simply just ensuring a better implementation of recommendations for the multiple comorbidities that they face, and better treatment of the perimenopause time of their lives as they age would ensure better health outcomes for women. The transgender population is growing, and as they age, I think there are several gaps in our understanding of how to optimally manage this population. First of all, the hormonal treatments that they take and how these will interact with antiretroviral therapy and other comorbidities, and also whether this group would have a different pattern of comorbidities as they age. And I think there's much that we do not know about this population and ensuring their optimal care as they age. The multiple comorbidities, as I mentioned earlier, are particularly interesting in the setting of HIV for my mind, because of the way that these can cluster. And this invites speculation that potentially this clustering could offer an opportunity for a simple pathological pathway and a simpler intervention, and thus addressing many of these comorbidities at once. However, the exact drivers of HIV and how this intersects with the aging process and the accumulation of these comorbidities over time remains to be explored. Long-acting antiretroviral therapy and novel mechanisms of action offer huge opportunity for people living with HIV as they age, but there is much that we need to understand in terms of how these drugs are differently metabolized by aging skin and aging muscles, and also whether the long-acting drugs also come with long-acting adverse outcomes that need to be addressed differently in an aging population. We have known for several years that many of the comorbidities are benefited by changes in lifestyle and exercise. However, in a setting of aging and in the setting of HIV, we still have a lot to understand exactly what is driving the musculoskeletal manifestations of HIV and how exercise could benefit or not this population. PrEP is specifically targeted at a younger, more sexually active population, but of course the elderly are still sexually active too, and it is really important that we are able to engage in the older population who are at risk of HIV and ensure that they are both included in the clinical trials that we conduct for PrEP, but also that they are ultimately able to benefit from PrEP. And at the moment, I think this is somewhat lacking for this group. So our outreach to the older folk at risk is far less robust than it is for the younger folk. Vaccines, we know, are far less likely to respond effectively in an elderly population with an aging immune system. So the therapeutic and the preventative vaccines that we're developing for HIV need to take this different response to vaccines into account when addressing the needs of the older population. And then finally, a cure. So the promise of cure is extremely exciting and looking increasingly likely in the next several years. However, there are likely to be different responses to the cure strategies in an older population. And I think we need to ensure that in the absence of HIV, we don't have this offset in the older population by a myriad of comorbidities. And then finally, stigma. So the prolonged stress associated with stigma has substantial immunological, neuroendocrinological, and neurobehavioral consequences. The immune contributions to stress resilience and coping is likely perturbed in aging, as it is in HIV, and those who are subjected to long-term stigma. So is there an immune molecular signature of stigma and stress resilience in HIV? And how does HIV influence the co-regulation of the stress response by the hypothalamic pituitary axis, the autonomic nervous system, and immune response in aging people living with HIV? So in summary, the majority of HIV infections are in younger adults, and these are now fortunately aging, but they're aging with consequences. And often the same cellular processes that are impacted by HIV are those that are impacted by aging. The increasingly prevalent elderly population living with HIV are not a special population, but represent the most clinically challenging group, characterized by systemic inflammation, multiple comorbidities, polypharmacy, and the societal inflictions such as stigma. Our regulatory agencies have long recognized this complex nature of drug development intended for the elderly, but there are significant gaps in how we are able to ensure participation of the elderly in our clinical studies. And of course, the major challenges that are now emerging for people living with HIV are not only going to be able to be addressed by drug discovery and development. And as an industry, we need to ensure commitment to this population, recognizing their complex needs and addressing issues like stigma, and ultimately ensuring that when a remission or cure is secured, it is not offset by a myriad of age-associated diseases. So thank you for listening and giving me the opportunity to present some thoughts. I'll just leave you with some additional EMA and FDA resources. And you should be able to click on these and it will take you to these links. Thank you.
Andrew. Our next speaker is Jose Castillo Mancia, got it backwards, from UC Denver. Jose is an associate professor in the Division of Infectious Diseases and is very active in the development of drugs for HIV treatment and prevention. He is trained both in infectious diseases and in clinical pharmacology. And the title of his talk is Aging, Monitoring Drug Levels, Changing Dosing, Adherence, Long-Acting Agents. So Jose, I will now turn the podium over to you.
Well, thank you very much for the introduction. I would like to thank the organizing committee and in particular Dr. Christine Erlandson for the opportunity to speak with you here today. This is actually my first time at this conference and I'm very excited to participate and to learn from all of you. And as you can see by the title of this talk, we have a bit of ground to cover today. So what I would like to do in the next 18 to 20 minutes or so is to talk to you about some of the changes that aging exerts on the pharmacokinetics and adherence of antiretroviral therapy. And I would like to focus a little bit on some of the methods that are currently available to quantify adherence and how do they relate to older patients living with HIV. I think we're also going to review today some of the antiretroviral therapy along the aging continuum. And I will try to discuss with you some of my thoughts on the possibility of dose modification for older adults in the age of modern therapy. I will also touch a bit on the new formulations that are becoming available to treat HIV, in particular long-acting injectables. And I will finalize my talk with what I think are the main knowledge gaps in the field and provide you with some ideas on what the research agenda is going to look like, I think, in the next decade as we move forward. So I think everybody in this audience is well versed on the changes that are driven by human physiology during aging. And I think several of them are very influential to pharmacokinetics, not just of antiretrovirals, but all of drugs in general. For example, we know that older adults have lower free water to and a higher adipose tissue, and decreasing their free water to fat ratio. And that increases there are also decreases in lean body mass. This has a significant impact on the volume of distributions, such that drugs that are polar have a smaller volume of distribution and a shorter half-life in comparison to drugs that are not polar and are fat-soluble that usually have a larger volume of distribution and a longer half-life. Drug absorption and plasma proteins are also decreased in aging, and that impacts the amount of free drug available in plasma in some older adults, and that may impact some of the efficacy of the drug. And renal excretion and hepatic blood flow are also decreased during aging, with a concern of potential decreased hepatic metabolism of some medications. So all these changes together can result in variable pharmacokinetics, which may impact drug efficacy and may narrow the therapeutic index of a drug and lead to more toxicity. Now, along with the physiologic changes that are present in aging, there are also some pathologic changes that can influence drug pharmacokinetics. For example, with aging comes the accumulation of comorbidities. And these comorbidities can impact pharmacokinetics not only due to an accentuation of the physiological changes that I already mentioned, but also to the addition of new drugs to treat them that can alter drug absorption, metabolism, distribution. Similarly, with aging comes high inflammation. And we know that inflammation actually affects the expression of some transporters and some proteins that are metabolizing proteins, for example, like the cytochrome system, that can lead to a slower metabolism of some drugs. Also, cell senescence that is seen with aging can impact pharmacokinetics, particularly of those drugs that undergo intracellular metabolism, like some of the antiretrovirals we use currently in clinical practice. So what do we know actually about the pharmacokinetics of antiretrovirals in older adults? Well, in reality, we don't know much because there really have been only very few studies that have been controlled to evaluate pharmacokinetics in this population. For example, data from studies in nucleoside analogs initially demonstrated no differences in the pharmacokinetics of abacavir, for example, while studies that looked at lamivudine and tenofovir actually found that the age correlated with drug concentrations and clearance of these drugs. Regarding other classes like non-nucleoside analogs or protease inhibitors, I think the general consensus has been that age has not really been a big influence on drug concentrations of these classes. And this also seems to apply to integrase inhibitors, although data are less limited. And there was actually a recent study that observed increased exposure to dolutegravir in older adults, but really without any clinical consequence to note. The problem that I personally see with all the studies looking at the pharmacokinetics in older adults is that they have actually focused on plasma drug concentrations as the primary outcome to evaluate. And I think while this makes sense, I think most of the studies have overlooked the opportunity to look at drug concentrations at the site of action. Although this has been recently looked at, for example, several years ago, a study looking at nucleoside analogs and their phosphorylated metabolites intracellularly identified no differences in the concentration of phosphorylated lamivudine or cytobudine in older adults. However, a couple recent studies actually found higher concentrations of tenofovir diphosphate and M-tricytidine triphosphate in peripheral blood mononuclear cells in adults who were 60 years and older. This was also similar to studies that identified high concentrations of tenofovir in hair and tenofovir diphosphate at spots in the same population. What is interesting in these couple of recent studies is that these findings became less significant after the studies controlled for covariates, which I think raises the point that it's not chronological age per se, but it's the factors associated with aging that are the ones that likely drive these differences. Now, similar to the influence of pharmacokinetics in aging, aging can also exert significant impact on adherence and behavior, which is what I'm showing here. For example, as people get older, they accumulate comorbidities and they increase their pill burden. And if they have had a chronic illness for many years, they eventually may get tired of taking medications because either they don't want to take them anymore or they don't think they are necessary anymore. Unfortunately, older adults are also prone to social isolation and loss of emotional support, and alcohol intake may also increase as people get older. You can imagine that these behavioral changes can be accentuated and exacerbated by the presence of mental health comorbidities, like, for example, depression or anxiety, which are highly prevalent in older adults, and also, of course, by cognitive decline. So collectively, these factors can contribute to low adherence, whether it's intended or unintended, and influence drug efficacy. And similar to the data we have in pharmacokinetics, the data that we have on adherence to antiretroviral therapy in older adults is also limited and conflicting. If we look at for example, if we look at adherence to antihypertensives in the general population, for example, we see that older adults, particularly of minority backgrounds, have lower adherence to antihypertensives with an impact on blood pressure control. But when we look at blood pressure, at antiretroviral therapy adherence in particular, we actually see the opposite. And we find that older adults in the study had a higher adherence compared to their younger counterparts in the ratio of about 20 to 30% higher. However, despite these, the rate of viral control and viral suppression in older adults of greater than 55 years old is still only 60% according to data from the CDC. So I think the true level of adherence in this population is not yet fully characterized. And if we were to take a closer look at the factors that drive adherence in older adults, I already mentioned pill burden at the beginning, earlier in the talk, and I think it's a well-known fact to many of you that polypharmacy, which we usually define as taking 5 or more medications, can actually translate into lower adherence to antiretroviral therapy and many other medications. Other factors like female gender or residing in a rural community have been associated with low adherence, while other factors like high income and high self-efficacy have been associated with high adherence. And as you can see, obviously adherence is a very complex concept, and the complexity associated with it in the general population accentuate as people age. I do want to say a word about polypharmacy, which of course has an impact on antiretroviral adherence, as I mentioned. As you can see here from this study in Spain, where polypharmacy was associated with the lower odds of achieving high antiretroviral adherence of 90% or more in our population in Spain, and with the impact that it has in viral suppression. And polypharmacy is not only associated with adherence, but it also has been associated with high incidence of drug-drug interactions and with functional decline. But I think it's not just the number of medications what matters, but it's actually how complex a regimen is. And regimen complexity is actually dictated by factors such as, for example, how many times a day a medication is taken, whether it's an oral route versus an injection, whether it's supposed to be taken with food or on an empty stomach. And the medication complexity can actually be quantified numerically using a standardized tool. At least in HIV, seems to be primarily driven by non-antiretroviral medications, as you can see here in this study from Colorado. Just to orient you, in the y-axis here, we have the complexity score that can go from 0 to infinity, for example. And you can see that the contribution of antiretroviral therapy in black is not very high compared to the contribution of non-ART medications in light gray and the contributions of over-the-counters in dark gray. And recently, high medication complexity has been associated with lower antiretroviral adherence and lower cumulative drug exposure in persons with HIV. Now, I've already told you that quantifying adherence is important, so I guess your next question is going to be, well, can we really accurately measure? And well, to achieve this, we have a wide range of adherence measures, as you can see here in the slide, that go from, for example, self-report as the most objective one in the left of the slide, all the way to directly observed therapy as the most objective in the far right. And as you can imagine, every single one of these measures has limitations that we can talk about. And even directly observed therapy, for example, has its hurdles. I do want to emphasize that HIV viral load in this spectrum sits pretty much in the middle, and that a suppressed viral load doesn't necessarily mean high adherence, and particularly now in the era of modern art and potent As you can imagine, quantifying adherence in older adults comes with its own challenges. For example, self-report, which we use regularly in clinical care, is very prone to be affected by recall bias, which can be accentuated in some of our older patients who have cognitive decline, for example, or memory problems. If we get into more sophisticated methods, for example, like electronic monitoring, we will definitely run into barriers with implementation and learning of technology. And there was actually a study that found that poor attention span and poor executive function were associated with inability to correctly use electronic adherence monitors. An exciting new field is the field of digital pills, which basically are ingestible biosensors that are combined with medications to objectively quantify drug ingestion and when the sensor that is attached to the pill reacts with the gastric fluid, it generates a small electrical signal that is transmitted into a relay system that is usually outside of the body, like in a lanyard or a patch. And that signal can be transmitted then to the cloud. One of the advantages is that these readers can also quantify physical function, vital signs, etc., which are also interesting and could be helpful in older patients. Obviously, digital pills are early on development, have these advantages that will need to be addressed before they can be implemented. One of them is going to be learning the technology in some of our older patients, but also cost and concerns about implementation and privacy are going to have to be addressed. If we move now into pharmacologic measures of adherence, I think the key here is to understand that the information that these pharmacologic measures are going to give us is directly dependent to the half-life of the molecule that we are measuring and in which matrix we are measuring. So for example, if you look at the top of the figure here above the dotted line, you can see that plasma, urine, tenofovir concentrations, and tricytidine triphosphate in dry blood spots are measures of short-term adherence and recent dosing. And this is due because their half-life in those matrices runs very short, in the order of hours to days. In comparison, if you look at the lower half of the slide below the dotted line, you can see tenofovir diphosphate in dry blood spots, and drug concentrations in hair are measures of cumulative adherence, which is due to their long half-life in these matrices that runs in the order of days to weeks. So if you were to think about it in terms that are very familiar to all of us, like diabetes, for example, your upper half of the slide will constitute your glucose measurement, while the lower half of the slide will constitute hemoglobin A1C. Measures of cumulative adherence, like drug concentrations in hair and dry blood spots, have actually been associated with viral suppression and are actually predictive of future viremia. But the limitation is that they actually have only been evaluated in one study comparing older versus young adults. And this study found no differences in drug concentrations in these matrices in adults older than 60 years old compared to younger persons with HIV who were virologically suppressed. The limitation that these measures will have is that, for example, hair may not be always available in older adults, and there's also an influence of hematocrit on drug concentrations of dry blood spots, which an hematocrit tends to decrease with age. So if we accept the premise that drug exposure, that aging is going to actually lead to high drug exposure, we could propose that aging actually influences two critical outcomes in HIV care. One is viral suppression, and that is basically related to drug forgiveness. Forgiveness being defined as the ability of an antiretroviral to maintain viral suppression when adherence is less than 100%. Now we know from recent studies that patients do not have to be 100% adherent to be suppressed, and that actually 80 to 85% adherence may be enough to maintain suppression, which is a great advantage of the new drugs. But what the problem is that incomplete adherence is actually associated with higher immune activation and higher inflammation and coagulopathy, even in persons who are virologically suppressed. And these actual consequences have been associated with mortality in persons with HIV. And we also do not know if incomplete adherence in a very forgiving regimen over time can actually lead to the development of drug resistance in the long run. The other clinical outcome that high drug exposure would affect would be drug toxicity, which in part is mostly driven by high drug exposure over time. Well, we are all familiar with some of the adverse events and effects that many antiretrovirals have. I think we need to focus a little bit more on the consequences of high cumulative exposure over long periods of time, And we have recently learned that high exposure, as measured by tenofovir diphosphate in dry blood spots, is associated with endothelial activation and monocyte activation, and also with decreased bone mineral density in the hip and poor physical function, all of which are risk factors for falls. So a question that comes to my mind is, well, can we get away with modifying those to reduce toxicity in older adults without compromising efficacy? And to answer this question, I think we can propose looking at aging, toxicity, and forgiveness in a graphical form. Here you can see in the upper panel that as age increases, toxicity will also increase and will eventually cross a hypothetical threshold for organ damage that is presented here in the dotted line. Comparatively, in the lower panel, you can see that forgiveness also increases as a function of age. And this could be viewed as beneficial, of course, as I mentioned earlier before, in many patients. Now, if we're going to perform a dose modification to decrease toxicity, for example, we're going to have to look at some of the specific patient characteristics that may be influential in these relationships. So, for example, if we were to choose a body mass index as an example, we could potentially see that a dose reduction in someone with a high BMI could be associated with a decrease in toxicity below the threshold of organ damage, as shown here in yellow. But if this dose reduction is coupled with a very impactful decrease in forgiveness that falls below the threshold for viral suppression, as you can see there in yellow again, I think that is obviously something we would not pursue. In the contrary, for example, if the ideal case scenario would be a dose reduction in someone with a low BMI, in which considerable reduction in toxicity is achieved below the organ damage threshold, with very minimal impact on forgiveness, as seen here in blue. And these patient-related characteristics doesn't have to limit to BMI, but could be driven by physical function, inflammation, concomitant comorbidities. And I think we're going to have to look at those more carefully in the future if we want to evaluate these potential interventions. Fortunately, now we are facing the era of antiretroviral therapy, where monthly or every 2-month injections with long-acting antiretrovirals are available. Certainly, we're going to have to face some challenges when we provide these drugs. I mentioned at the beginning of the talk that muscle mass decreases by 30% with aging. And one of the questions that comes to mind is this going to lead to erratic absorption of injectable formulations in older adults? We don't really have a lot of data on the 2 available drugs that have been used for injections, like cabotegravir and rilpivirine. We do know a little bit that rilpivirine showed similar efficacy in previous studies in adults that were 50 years or older. But what we do have is actually accumulation of experience of long-acting medications, like, for example, antipsychotics in the older population. And I think that's something that will be encouraging in the future to use this mode of delivery. You may be familiar with the Atlas and Flare studies that recently shown that long-acting cabotegravir and rilpivirine were non-inferior to oral antiretroviral therapy. But the problem with these studies is that only 30 participants in the phase 2 and phase 3 studies actually were older than 65 years old, 65 years of age. Although they didn't seem to be any difference in this population, but the data are limited. Now, for this talk, I actually looked at 4 different antiretroviral guidelines to see if they were addressing treatment in older adults, and found that only 2 of the treatment guidelines have a specific section dedicated to adults, and none of them provided specific recommendations geared towards the optimal treatment or optimal regimen for older adults, and none of them discuss those modifications in this population. So I think moving forward, there is still a lot of work that we need to do to address some of the knowledge gaps that I just mentioned. And here in this slide, I try to present what I think would be the research agenda in the next decade when we look at the intersection between aging, pharmacokinetics, and adherence. First, I think we're going to have to identify which regimens have the most favorable pharmacokinetics and the lowest toxicity, and also perform studies of long-acting injectables specifically geared towards older adults. I think we're also going to have to try to better understand antiretroviral forgiveness in this population, and what are the best and most informative adherence measures in older adults. And we're also going to have to understand what are the consequences of overexposure over time. And I think we have to give at least a consideration to perform clinical trials of dose reduction in adults who are 65 years old or of age or older. So in conclusion, I think the influence of adherence and pharmacokinetics, I hope I convey the message that those are very complex and not yet fully understood. But I think this knowledge gap is actually limiting the ability for us to provide the highest benefit of art of antiretroviral therapy that we can to our older patients. Quantification of adherence in this population will continue to be a challenge, and we'll need to figure out the ideal measure to quantify adherence in older patients with HIV to improve clinical outcomes overall. And I think we have a very broad agenda in terms of research ahead of us, with the goal to optimize therapy by minimizing toxicity without compromising efficacy. And with this, I would like to thank you for your attention and for the opportunity to be here. I would like to thank all my friends, colleagues, mentors, and collaborators that are listed in this slide, our study funders, but most importantly, every study participant who has donated their time for the research that is presented in these slides. I appreciate, again, the invitation, and I am happy to take any of your questions. Thank you.
Thanks, Jose. That was terrific. So we now have a few minutes for questions and answers live with Jose and Andrew. There have been several questions posted on the conference website. All of those so far directed to Andrew. But if you have questions specifically for Jose, now would be a good time to go ahead and type those in. So Andrew, the first question was directed at you, but I'm going to ask both of you to respond to it. The question is from Jules Levin, and he says, how will overall HIV care costs increase with increasing numbers of people living with HIV? It's estimated an individual PLWH care costs for one patient 65 years or older will be 4 times greater, I'm assuming greater than someone less than 65. How do you think the increasing costs will affect the overall HIV care infrastructure? And let me add to that the fact that in many high-income countries, including the United States of America, once people retire, their annual income drops significantly. And it's estimated in the United States that 57% of people over the age of 70 operate under the poverty line. And so how do you think the care infrastructure will need to change to accommodate an increasing number of older patients living with HIV?
Well, I think it is quite obvious that we're already seeing evidence that the costs have increased for people with multiple comorbidities. So each comorbidity obviously will have its own associated cost, but it also depends, I think, largely on the healthcare infrastructure and where people are cared for. So if it's largely outpatients and medication, that's a relatively lower cost. But as soon as you have hospitalizations and in-hospital care or care home type of care, then that will go up. But I think one of the biggest issues to me that is not addressed is what happens to people who do need care that are living with HIV in a long-term situation, so like a care home, where they're going to be faced with, I think, quite a considerable amount of stigma. And so those are going to be quite problematic because that will increase the care cost significantly if they have to then find private institutions that will look after them. And I don't think we're set up to address that, but it is very obvious that care costs are going up. And there's one other thing is for people that have been living with HIV for a long time and have quite significant immunocompromised state, like a low CD4 count, for instance, we know that the cost of care goes up by the inverse relationship to CD4 count. So there are several factors, I think, that are driving costs.
Thanks, Andrew. Jose, do you want to add to that? Do you want to comment on that, the potential impact of the economics of aging on the pharmacology of aging?
I agree with what Andrew mentioned. To be honest with you, I think his answer was comprehensive. But I do want to touch. I do have a question for Andrew, if I may, or I don't know if you're planning to continue.
Sure.
Andrew, when you were talking about the long-acting studies in aging persons, older patients with HIV, what do you think overall is the kind of the agenda for pharma industry to assess long-acting injectables, at least since they're the most advanced in development in a specific population of older adults?
I think the advantage of injections is that it gives patients a different, well, it gives people who are given those injections or other forms of administration other than oral, it gives them a freedom from having to store the stuff and having to go and take stuff every day. So that's all well and good if that's all you need to take. But if you're still having to take other oral medications, then I think the benefit of that goes away, and except of course the stigma that's associated with certain diseases like HIV. So you can still have some benefit. But I think beyond that, and from the sort of longer term view, even beyond injections, there are several other ways that we can administer long-acting medications, such as skin patches and different types of access that don't necessarily require an injection, so implantables and things like that. I think there are lots of other opportunities that are of benefit. And for the older population, particularly those with neuropsychiatric or neurocognitive problems, this is great because they don't have to remember to take anything. It's as long as they remember to go and have their as they need it.
So I want to remind the audience that we will be having a roundtable panel discussion on the delivery of care for folks aging with HIV later in the workshop, and I would strongly encourage you to listen in on that and participate as an audience member, because there will be a chance to discuss a number of these issues in much greater depth with a group of experts. So Jose, I have a question for you. You talked about the possibility of doing dose individualization for individuals with overexposure to ARVs, not something we normally think about in clinical management. But do you want to comment on the practicality of that, as therapeutic drug monitoring hasn't really caught on as an HIV management tool? Do you think that's going to change as we have more people living with HIV over the age of 65 and perhaps living with HIV with higher drug concentrations than would be seen in younger patients?
Thanks, Charlie. No, I appreciate the question, and I realize obviously it's challenging and kind of a little bit out of the box, if you will, thinking at some point. But a couple things about that. I think that we, as our patients are going to age, we are going to have to face potentially thinking about this. The therapeutic drug monitoring question that you brought up, I think what we perhaps have been measuring may not be the optimal potential outcome in terms of drug concentrations that we want to assess for exposure overall, as many of the studies of TDM have focused in plasma concentrations. I think now that we have measures of cumulative exposure like hair, DBS, or others, we may be able to extrapolate a little bit more information in terms of long-term exposure. I realize that the practicalities of modifying dose on single tablet regimens that are implemented particularly to facilitate adherence is not going to be something relatively straightforward. But at the same time, at least evaluating the possibility of this and perhaps what would it look like in some of our older adults is something that I did want to bring up in the agenda, because I wouldn't think we're ready to let that go or forget about it without a little bit more, at least thoughtful discussion in the future. We also have not performed those modifications before in older adults based on kind of non-measurable or less easy measurable outcomes or predictors like frailty, physical function, etc. And I think those are important questions to raise, at least in my opinion.
Terrific. So with that, we need to end this session. I would like to thank our speakers, Andrew Clark and Jose Castillo-Mancia. Two excellent presentations, a very interesting discussion. Thank the audience for participating. We're now scheduled for a break, and our next session is scheduled to go live at 3:15. So please take a break and come back and join us. We look forward to having you back.